Good day and welcome to Epstein Becker Green's webinar, Enforcement Trends and Risk Mitigation for Home Health and Hospice Providers. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are welcome to submit questions throughout the program using the Q&A feature provided by WebEx, and at the end of the program, with time permitting, the speakers will address your questions. You are also welcome to submit questions directly to the presenters following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We are pleased to have 4 fantastic speakers today. Epstein Becker Green's David Matthias, who is a member of the firm in the Healthcare and Life Sciences practice, and the firm's Washington, D.C. office, where he serves as the managing shareholder of the office. Jason Christ, a member of Epstein Becker Green's Healthcare and Life Sciences practice in the firm's Washington, D.C. office. Emily Baichi, an associate in Healthcare and Life Sciences practice of Epstein Becker Green in the firm's Boston and Washington, D.C. offices. And finally, Sarah Schlanger, an associate in Healthcare and Life Sciences practice in the Washington, D.C. office of Epstein Becker Green. At this time, I'd like to turn the webinar over to David Matthias.
Thank you very much. So the 4 people that you have in speaking today are all members of our healthcare practice, and in particular part of our fraud and abuse practice group. All of us focus on regulatory compliance issues with an emphasis on defense work on government investigations. All 4 of us have spent a large portion of our careers dealing with issues in the home care industry, both home health and hospice. And what we wanted to address today were various risk areas and kind of the state of affairs as it relates to fraud and abuse in these particular industries. There's a whole host of risk areas that are being looked at and assessed by federal agencies, including employment issues, infection control, quality of care, but today we're focused on some of the fraud and abuse issues under the Federal False Claims Act and other statutes that we'll talk about in a moment. What you see here is a slide basically exemplifying how the headlines today focus a large amount on the scrutiny that the healthcare industry and home care in particular is currently undergoing. And why this increased emphasis over the last few years on home health and hospice? Well, one of the reasons can be assessed is that as the healthcare industry is being pressed to decrease the amount of spending in acute care facility settings, there's an increased spend in the home care industry. And once the government starts to spend more of its dollars in particular industries, the government enforcers start to also focus on potential wrongdoing in those industries. Today we're going to talk about 4 basic areas. First, we're going to address what some of the significant federal laws are that are being used by the key enforcers in this arena. Secondly, we'll be addressing some of the focus areas that the government enforcers are focusing on. Third, there have been, in addition to the federal enforcers going after healthcare fraud, there's also been several regulatory responses to trying to mitigate some of the risks prospectively by the federal government. And lastly, we'll provide some opportunity to address ways in which members of the home care industry can proactively mitigate some of its own risks in this time of increased scrutiny. So let's move to the first topic, which are some of the federal laws and the key enforcement players. Jason, can I turn it over to you?
Thanks, David, and thank you everyone who is attending today. I hope what we're going to do today is provide very timely and useful information, not just for home health and hospice providers who are attending, but also to the investors, payers, integrated delivery systems, health systems, and other stakeholders who have joined who have an interest in these 2 industries. As David mentioned, both the home health and hospice industries have been the subject of some high-profile investigations, prosecutions, and there's been a lot of recent settlements in this space. So I think we're going to start by looking at the authorities the government uses to bring cases against home health and hospice organizations. So the two most prominent laws are the Anti-Kickback Statute and the False Claims Act. The Anti-Kickback Statute is a broad prohibition on the offering or providing anything of value in exchange for referrals for items or services payable by federal health care programs, of course, including Medicare. What constitutes remuneration is very broad. It's really anything of value. It could be cash in kind, gift cards, rebates, in excess of fair market value compensation, discharge of debts, really anything that has value. There's a lot of safe harbors that Congress and the Office of Inspector General of HHS have issued over the years that permit certain kinds of financial relationships between providers and referral sources. We're not going to go into those in detail today, but the industry should know that this prohibition does attach to those financial relationships with referral sources such as nursing homes, physicians, social workers. Really everyone who's in a position to refer or influence decision-making for home health and hospice is potentially implicated by the Anti-Kickback Statute. More recently, we've seen a lot of enforcement, and not just those sort of external entities that provide a source of referrals, but also the internal resources and employees of an organization. If home health or hospice employees are incentivized to admit patients, recertify patients, or meet certain goals, that can also trigger liability. It's a criminal statute, and it also can sort of poison all of the claims that are associated with the tainted referral and make them all false claims. The Civil False Claims Act provides broad liability for the submission of any false claim to the government. It's arguably the most prominent law in healthcare enforcement. It wasn't originally designed to be that way. It was passed during the Civil War. But it has a very, very broad scope. There's a requirement that the false claim is submitted knowingly, but the courts have narrowed, or rather expanded, what knowingly really means, and it's sort of now interpreted as deliberate ignorance or reckless disregard. So it's a relatively low threshold, at least according to a lot of federal enforcement agencies. The reason that the False Claims Act has become such a prominent enforcement tool is largely due to the key TAM provisions of the False Claims Act, which allow private citizens, whistleblowers, they're also called relators, to bring a complaint on behalf of the federal government. That complaint's filed under seal, and the Department of Justice, through its assistant U.S. attorneys, has an opportunity to review the complaint and decide whether it wants to intervene. If it decides to intervene, it can settle or litigate, and if it declines to intervene, the relator can still go forward and sue the company. The relators, these whistleblowers, often come from current and former employees, but actually in the hospice and home health space, we've seen quite a few coming from competitors and vendors. The damages, of course, are draconian, stated lightly under the False Claims Act. There's significant penalties plus a treble damage provision for the court would award. And notably, the False Claims Act applies to so-called reverse false claims, which include the withholding of monies that the organization is not entitled to. We're not going to go through all the laws. Briefly, there's the Stark Law, there's the civil monetary penalties provisions of the Social Security Act, and there's a number of other criminal and civil healthcare fraud provisions, mail and wire fraud, obstruction, false statements, RICO, money laundering. There's a number of different causes of action that the government can bring against organizations. I think it's important to know, though, that some of these provisions, like false statements, obstruction of justice, some of those charges actually are incurred after the government makes its overture after it issues its subpoena, and it's largely because someone at the organization has acted inappropriately and has attempted to obstruct justice by shredding or deleting responsive materials, or lying to an agent or grand jury, or otherwise interfering with the government's investigation. So, it's really important that these investigations be treated very, very seriously, and that counsel be involved early. I think we could probably rename this slide to the alphabet soup of government enforcement agencies. There's a lot of them, and this is not by any means an inclusive list. The Department of Justice, of course, through its U.S. Attorney's offices, brings False Claims Act cases. The FBI is the investigative arm of the DOJ, and it gathers evidence and builds cases, makes recommendations. The OIG, the Office of Inspector General of HHS, is responsible for enforcing the civil monetary penalties, but it's also responsible for the imposition of exclusion. The exclusionary authority, is sort of the death knell to most institutions. It prevents providers from submitting claims to federal health care programs. And often, as a consequence of a settlement with the government, the OIG will waive its exclusionary authority in exchange for a corporate integrity agreement, a CIA. They often last 5 years and have training and monitoring, and can be quite onerous on institutions. There's the state attorney's offices, the MAFUCUs. There's been a lot of movement to pass state false claims acts, and they attach to Medicaid receivables. And there's a number of different program integrity contractors, and we're not going to go through the entire list here, but there's other agencies we haven't listed: the Veterans Administration, the Office of Personnel Management, Department of Defense, and significantly, what's missing is whistleblowers, who are another huge key enforcement player.
Emily, can you start to talk through the issues of what the government enforcers are focused on right now in the home health and hospice industries?
Yes, thanks, David. Happy to. And before we delve into the specific areas of home health and hospice enforcement, we want to spend a few minutes on enforcement trends more globally. Enforcement efforts across the agencies and the contractors that Jason highlighted are producing an unequal return on investment. And this high rate of return is really a driving force behind the continuing increase in healthcare fraud investigations and prosecutions. The 2014 numbers were just announced. Overall, civil False Claims Act recoveries this last fiscal year topped $5.7 billion, with healthcare fraud recoveries second only to those in the financial industry. Healthcare fraud is generally the largest share, and even in second place this year, the federal government exacted $2.3 billion from individuals and entities in the healthcare industry. This marks the 5th consecutive year of more than $2 billion in annual healthcare fraud recoveries, and these numbers are only for civil cases. They don't include criminal penalties, and they also don't include any state Medicaid monies that are recovered as part of federal-state joint settlements. As a result of its effort, the government is seeing a 3-year average rate of return of $8 for every dollar expended. That's really an incredible rate of return on investment. And so it's not surprising to see that in 2013, DOJ opened over 2,000 criminal and civil healthcare fraud investigations, roughly 1,000 of each. HHS OIG, similarly, they had investigations at 850 criminal actions and over 450 civil actions against individuals or entities. Similarly, last year, RACs returned more than $3 billion to the Medicare trust funds. They also had a high rate of return compared to their program costs. Specific to home health and hospice, RACs recouped $6.3 million in overpayments from home health, and a smaller amount, just $35,000 from hospices. We'll discuss this a little bit more later. Home health has been on the radar of RACs more than hospices, but we think that this may well be changing. Currently, there are 4 RAC contractors with their audit responsibilities assigned by region. As part of the new RAC contract procurement process, which is currently underway, CMS plans to award a 5th national RAC contract. It'll be specific for home health, hospice, and DMEPO's claim reviews. Home health and DMEPOS providers have been designated as high-risk provider types by CMS, so it's not surprising that we see more resources being devoted here. And we believe that the inclusion of hospices under this RAC contract may also signal that hospices will see increased audits and scrutiny. Overall, we anticipate that home health and hospice will be a large area of focus for RACs in the coming year, as CMS has indicated they hope to award this contract by year's end. There has been some controversy surrounding the RAC audits, particularly because RAC auditors receive a cut of the amounts that they recover. So we anticipate some changes will be made as part of the current rebid process, but clearly the RAC program is here to stay. Similarly, just touching on the ZPICs briefly, they were rate of returns are much smaller than those of DOJ, OIG, and the RACs, but they've still shown their value. In 2012, ZPIC actions resulted in more than $250 million in savings, and most notably, more than 130 ZPIC investigations were accepted by law enforcement agencies for potential prosecution. So in connection with the tremendous profitability of healthcare fraud enforcement, we're seeing a significant increase in the resources allocated to these efforts, and we want to just highlight two trends in these increased resources being poured into investigating and auditing fraud. The first notable investment is data analytics technologies. I just want to briefly mention the fraud prevention system, which some of you may have heard of. This is CMS's predictive analysis system. It was created under legislative mandate, and since 2011, CMS has been using this system to conduct prepayment screening of all Part A and Part B claims, and they are doing this to analyze billing patterns and anomalies. CMS has now also linked this, their claims processing system to the FPS, and this is enabling more automated payment denials. FPS is used in a number of ways. One of them is to generate investigative leads, and we saw that last year it generated over 460 new leads to ZPIC investigations. FPS is not only being used by CMS, but by a number of federal enforcement agencies, thanks to the big second trend in enforcement, which is collaboration. The most prominent collaborative effort is HEAT, the Healthcare Fraud Prevention and Enforcement Action. This was created by DOJ and HHS. It's a joint effort led by the Attorney General and the Secretary of HHS. Their focus is to coordinate resources. Their kind of most notable effort is the Medicare Strike Force. The Strike Force is criminal. The teams target emerging schemes in the healthcare fraud hotspots around the country. There are currently 9 cities in which they operate, and they execute large-scale takedowns, marshaling the resources across the government agencies. We've also seen an increase in criminal enforcement efforts generally. This fall, DOJ announced that the criminal division will now review all key TAMs to assess whether to open a parallel criminal investigation. So we anticipate that criminal prosecution will likely become an even more prominent part of healthcare fraud enforcement, and the government has voiced a concern that penalties enacted under civil enforcement actions may not be sufficient to curb some abuses. And just finally briefly touch on one of the newest partnerships, which is a private-public partnership, and that's the Healthcare Fraud Prevention Partnership. This is a collaboration between federal and state governments, as well as private insurers and trade associations.
Before we move on to the next section, to recap, it's really important to know in today's climate there are multiple agencies, there are numerous federal contractors. There's a panoply of tools and theories that the government can use to establish liability for home health and hospice providers. And these agencies now, and this is a more current development, are much better funded and trained. And Sarah now is going to talk a bit about some of the home health statistics that really make the case that continuous government enforcement is going to happen in the future.
Thanks, Jason. So the latest report from MedPAC, and for those of you on the phone who aren't familiar with MedPAC, that's a nonpartisan government agency that analyzes the Medicare program for Congress. And their latest report showed that there's been tremendous growth in the home health industry over the past few years. And these numbers help demonstrate why home health is a continuing target for the government enforcers. Approximately 3.5 million beneficiaries received services from more than 12,000 home health agencies, and Medicare spent approximately $18 billion on those services. MedPAC also noted that government spending on home health care has doubled over the past decade, and the number of agencies continues to grow every year. Interestingly, MedPAC did comment that almost all of the new home health agencies since 2000 that have entered the space are for-profit entities, but certainly both for-profit and nonprofit entities are under scrutiny by government enforcers. According to the OIG, nearly $1 billion in improper payments have been identified in the home health industry since 2010. So we really see that because of the money being spent on home health services, the government has taken a particular interest in looking at this industry. And the government publicizes its enforcement priorities in a few different ways. One way is the annual OIG work plan, which is a report that summarizes new and ongoing reviews and activities that the OIG plans to pursue during the fiscal year. The OIG work plan for 2015 was published a few weeks ago and shows that the OIG is planning to review compliance with the prospective payment system requirements with a particular focus on documentation requirements for home health providers. Now, as many of you are aware, documentation has previously been a focus of the MACs, so it's just an interesting change that we're seeing where OIG has also indicated that it will be scrutinizing home health documentation. Another area that the OIG intends to focus on in the coming year is the extent to which home health agencies employ individuals with criminal convictions. And they said that this is because nearly all of the states have laws that prohibit certain healthcare providers from employing individuals with certain types of criminal convictions. And they really want to make sure that those individuals going into beneficiaries' homes aren't, convicted criminals. The OIG work plan also included some areas of focus specific to the Medicaid program, quality of care, and the screening of healthcare workers. Again, these issues center on concerns about ensuring the safety of patients and who is providing services in the patient's homes. The OIG also publicizes its enforcement priorities through special fraud alerts and other reports. And these aren't necessarily issued on a regular basis, but instead are published when the OIG identifies trends or areas of concern that the agency plans to pursue and wants to let the industry know about these focuses. And many of the government's concerns that we're seeing are related back to a special fraud alert that was actually issued in 1995. So it's certainly a few years old, but still an ongoing area of concern. The concerns that were raised in 1995 focused on kickbacks and arrangements with referral sources, which we continue to see in the current enforcement actions. The RACs, which we mentioned earlier, also publish information about the different issues that they have been authorized to review, and information about those issues is available on each specific RAC's website. We expect that the new RAC, which is developed for the home health, hospice, and DMEPOS industries, will provide similar information once that contract has been assigned. And this list of issues really demonstrates that the RACs have found home health. They are looking at many of the same things that the other branches of government have raised concerns about. For example, the RACs are looking at claims for skilled nursing services that extend into the third episode to determine if Medicare coverage criteria is met. Similarly, the RACs are looking at medical necessity and that the medical record supports the patient's need for services. We can also see from this list of RAC issues that the RACs are utilizing the analytic technology that Emily mentioned earlier. For example, the RACs are looking at claims for visits that are billed during an inpatient hospital or SNF stay, and the RACs are looking at claims that do not include skilled services to determine whether the patient qualifies for home health services. And the RACs are able to identify these types of claims for review due to these data mining capabilities of this new analytic technology.
And in addition to the resources and issues Sarah just highlighted, OIG and DOJ investigative priorities can also be gleaned from recent enforcement actions, and we'll go through a few examples in a moment. For the most part, the issues being investigated in home health are not new, as Sarah had mentioned, and they continue to echo the areas highlighted in OIG's compliance program guidance for home health agencies. The bulk of enforcement really centered around a handful of risk areas, the first being medical necessity of home health services. Medicare provides coverage for home health services for beneficiaries who are both homebound and in need of either skilled nursing care or therapy. And as such, there's a lot of focus on whether beneficiaries are meeting either and both of these requirements. If a beneficiary requires one of these qualifying skilled services, nursing or therapy, Medicare also covers visits to home health aides and other disciplines. And as such, there's also significant enforcement focus on whether beneficiaries who receive home health services, who receive home health aid visits, also need a qualifying service. As Sarah had mentioned, MACs are also focusing in that area as well. Another issue is documentation sufficiency and compliance with CMS documentation requirements. The hot document issues in home health encompass not only questions around whether there's sufficient documentation to support the services were provided, but also around falsification and improper modification of documentation. For example, backdating of forms and signatures and clinical note amendments can give rise to concerns. There's a right way and a wrong way to make clinical note amendments, and when done the wrong way, the government can challenge the intent behind it. Sarah highlighted the compliance with CMS documentation is an enforcement focus. CMS implemented a number of these requirements as safeguards against fraud and abuse. Therefore, if requirements are not complied with, the government is suspicious of fraud. When we talk about technical documentation requirements, no requirement has given home health agencies a headache quite like the face-to-face requirements. Sarah is going to discuss the forthcoming changes in this area in a few minutes. But for the past 3 years, and for claims through the end of this year, CMS has imposed highly specific and confusing requirements for how the face-to-face encounter is documented. And HHAs have faced continuing challenges in ensuring how both staff and certifying physicians are going to comply with those myriad requirements. This also holds true for hospice, which has its own face-to-face requirements, which Jason will discuss. Another area of concern are financial relationships with referral sources. The two primary concerns are focused around whether the relationship incentivizes referral sources to steer beneficiaries to a particular home health agency, infringing upon a patient's freedom to choose which agency they want to use, and does the relationship encourage referral sources to provide or prescribe unnecessary care. As Jason mentioned earlier, problematic financial relationships can also be internal, and we see a lot of scrutiny of that here in the home health arena, taking a look at incentive compensation that's based on volume or productivity. Again, in the same vein, the government has questioned practices of marketing staff and their interactions not only with referral sources, but also with beneficiaries. Particularly of concern are interactions with patients prior to admission, and whether those interactions cross the line to beneficiary inducement through offering of free gifts or services. For example, OIG indicated in a 2006 advisory opinion that preoperative home safety assessments could implicate both the beneficiary inducement prohibition as well as the kickback statute. And just the final risk area to note briefly focuses around whether home health agencies are billing for services provided by unqualified personnel. Issues with home health aides are particularly prevalent here, looking at issues around whether those aides have the required certification and training, and whether aides are using falsified certification and training records. We now want to just highlight a few recent cases and some of the specific conduct that's been scrutinized by the government. One of the most prominent home health settlements, and one from this year, is with Amedisys, one of the largest providers of home health care in the country. The settlement was earlier this year in April. They agreed to pay $150 million to settle allegations that stemmed from 7 different key TAMs. One of the central allegations in this case was billing for unnecessary therapy services, which continues to be an area of particular scrutiny. The reason being is that in 2008, CMS changed their therapy thresholds, which are those thresholds where providers would receive a reimbursement bump, after concerns that providers were deliberately targeting the earlier therapy threshold in order to increase reimbursement. The 2008 rules set multiple therapy thresholds at 6, 14, and 20 visits, and what followed, CMS described as the largest one-year shift in therapy utilization since the implementation of PPS. Almost immediately, therapy utilization concentrated around the new threshold. And so what we saw was a Wall Street Journal analysis in 2010 on therapy utilization at the 4 largest publicly traded home health agencies, and then a Senate Finance investigation that followed. There have been calls to revise the home health payment model so that reimbursement levels are no longer tied to utilization. CMS did make some changes in 2011 and 2012, but the incentives remain. And because those incentives are still in place, we are seeing a lot of enforcement in this area. Two other allegations from Amedisys to just briefly highlight was the concerns around management pressure, both to nurses and therapists to provide unnecessary care. And the government also scrutinized a financial relationship that the agency had with private oncology practice, and specifically the care coordination services that were provided by the home health agency. Care All is a very recent settlement, again, for a sizable amount. The allegations are similar to some of those in Amedisys. What we want to highlight here was Care All's contention that the care that was provided was necessary, and that the issues that arose were really primarily issues with paperwork technicalities, and the services not being properly documented. And this really speaks to the point that we've been pressing in this webinar, which is that mere documentation issues can give rise to False Claims Act allegations, and the importance of having sound documentation practices. I'm also noting that this was the second settlement in 2 years for Care All. The earlier settlement focused around another risk area for home health, which was false cost reports to Medicare. I earlier mentioned the strike force, and their takedowns have swept up a number of home health agencies across the cities. One recent takedown was in October of 2012 across 7 cities, and these are just 2 examples from that takedown of specific home health agencies, both of which really primarily involved kickbacks. The first of which was a Louisiana home health agency. The allegations there, in addition to kickbacks to patient recruiters, were that nurses, including the nursing director, was falsifying documentation to make it appear as though beneficiaries qualified for the services. Also kickbacks to physicians to sign fraudulent referrals, as well as certifications for home health services. The second case in Michigan falls along the same lines. Again, kickbacks for referring patients. And here, the illegal payments were described as being disguised as bonuses, mileage reimbursements, and payments for medical director and consulting services. The final action that we want to highlight is an example of a Medicaid case. It's a recent case from the District of Columbia, and it's a case that's ongoing. The kind of raid took place earlier this year. More than 20 people were swept up in allegations of widespread fraud in the Medicaid program. Similar issues to what we've seen at the national level with Medicare fraud, and we expect state enforcement really to continue to increase as more and more states are going to take advantage of the incentive to adopt state false claims acts that mirror the federal statutes.
So Sarah, thus far we've kind of focused on the home health industry. What about some of the enforcement actions in the hospice industry?
I'm actually going to give that to Jason.
Oh, sorry about that.
That's okay. So the hospice industry, the government really has not made secret its reasons for focusing on the hospice industry. Home health has had a long-standing enforcement history with the government, but hospice is much more current. You need to only spend a little bit of time on DOJ, the DOJ website, looking at press releases. You can look at MedPAC issuances, things that CMS has published over time, to understand, very clearly why the government is diverting its resources towards hospice enforcement. It does what the government always does, and it follows the money. Medicare expenditures have, quadrupled since 2000, and a good case I think could be made that it's money well spent. The hospice benefit is designed to decrease end-stage care. There's a lot of curative medicine. And that happens in the last 6 months of a beneficiary that has, in some respects, no clinical benefit, and it's highly expensive. So the hospice benefit, was designed not only to provide the palliative side and the caring side and pain management, but also to decrease costs. So some of the expenditure increase may be as a result of sort of fee shifting. Nonetheless, depending on what government issuance you're looking at, it's pretty clear that government believes there's a lot of fraud in this area. Length of stays have increased, and the non-cancer terminal diagnoses of patients who elect hospice have also increased. And what makes the non-cancer diagnoses, I think, more challenging and certainly have a higher risk profile for hospice organizations is they don't follow a precise, linear pattern of decline and death. They're much more difficult to prognosticate, and it puts hospice organizations in a very difficult place with having that dual obligation to provide the highest care and treatment for its patients, but also have the obligation to make sure it's following government guidelines. The guidance in particularly with regard to hospice is really in a state of constant change. There's local coverage guidelines and national coverage guidelines, but they really don't cover the totality of all the various terminal diagnoses. So they're sort of safe harbors, but they don't cover everything. And what you have currently is this perfect storm of regulatory ambiguity and government expenditures, and it really makes this industry at the highest risk level for federal enforcement. So we went over the OIG work plan for home health. This is the one for hospice. They focused on nursing homes in the past, but now they're looking at relationships with assisted living facilities as well. There's been some guidance that's come out that suggests that the length of stay for beneficiaries who are in ALFs or SNFs has been longer. They're always concerned about the financial relationships between the two. Overuse of inpatient care. There's another level of service, a higher level of service in hospice called inpatient, and it's really designed to be episodic, but the government's concerned it's being overused, and of course it's billed at a much higher rate. There's an old fraud alert from 1998 which focuses on nursing facilities. Nursing facilities are particularly great referral sources for hospice organizations, and most of this fraud alert focuses on swapping, which is the hospice organization providing below fair market value services or free services that kind of shift the cost away from nursing homes in exchange for the expectation of referral. And even though this is quite an old fraud alert, these are still activities that are very, very closely monitored by the government. Briefly, we talked about RACs a couple times. As Emily mentioned, there's going to be a specialized RAC that's going to be looking into hospice in particular. There's currently 3 regions that are looking at hospice, and this is something we expect is going to be very significant in the future. There haven't been that many RAC recoveries thus far for hospice, but that's going to change. A lot of these are automated. They're looking to see if hospices are billing something that should be included in the global rate, the per diem rate, and there's a couple that are looking at the date of death because services can't be billed after the patient expires. This is by no means an all-inclusive list, but this should give you a good overview of what the most significant risk areas are for hospice. Medical necessity, I think, is always the first one for hospice. A patient should have a prognosis of 6 months or less to live, and that's the medical necessity guidance. That's the guidance of admissions, and if a patient doesn't meet that, the government won't pay for it. The government is particularly focused on long lengths of stay as well. These are defined by patients who have exceeded their second benefit period, which is at 180 days. And these are at a higher risk spectrum for hospice organizations, and these have become subject of just about everyone's audit. Failing to discharge. So this is where hospice is a benefit that contemplates an unlimited number of benefit periods, but in the government's view, at a certain point, a hospice organization, on a patient-by-patient basis, should conclude that a patient who is not no longer meets that criteria of the prognosis of 6 months or less should be discharged. And the government's looking to see if organizations are doing that in a timely fashion. Now, juxtaposing medical necessity from documentation, because the two are often very, very confused. Medical necessity is about appropriateness for service. Documentation is really about reimbursement requirements. There are a number of hurdles or loopholes, but requirements to claim submission that are imposed by CMS and the carriers. And they create a face-to-face requirement. There's certain certifications, physician attestations. There's other critical pieces of documents. And even if the patient is appropriate for hospice, even if services were provided, pursuant to all guidance, you still can't submit a claim if you're missing a piece of documentation, whether or not, for example, a face-to-face encounter occurred. So these are particularly frustrating, I think, for compliance officers because and organizations because you can still provide a good service, but you can't bill for it if you're missing a critical piece of documentation. We touched on marketing practices. I won't go through that again, but I do want to emphasize that in particular with this industry, having compensation related to meeting census goals, meeting targets, admitting patients, and otherwise incentivizing employees or agents to admit or recertify patients is a no-no, and this has been the subject of a lot of recent scrutiny. And I will tell you that hospices have closed or had payment suspensions over allegations for conduct that's on this slide. So it's a very serious issue.
Sort of following up on that, we've seen a pretty steady increase in the number of hospice enforcement actions over the past few years, and also a trend of the increasing dollar amounts for the settlements that have occurred. And although we've sort of categorized these actions based on the main risk areas for hospice, many, if not all, of the hospice enforcement actions tend to include some allegations about medical eligibility and appropriateness for the hospice benefit. This is partly because of the stringent documentation requirements that we've been talking about that must be met in order to demonstrate the patient's eligibility. In hospice in particular, eligibility is very closely tied to having the correct documentation. So the government may be able to make a medical necessity case or include claims that the patients weren't eligible for the hospice benefit in addition to any other allegations that are part of the lawsuit. We're just going to talk about a few of the recent enforcement examples for levels of and locations of care. In December 2011, an Arkansas hospice paid $2.7 million to resolve allegations that it submitted claims for general inpatient care when only routine care was needed. And this case was the result of a qui tam suit filed by a competitor of the hospice. So it's a good reminder that qui tam lawsuits can be filed by pretty much almost anyone, including competitors, disgruntled former employees, your contractors, your vendors. Really anyone can file a qui tam lawsuit. Similarly, in February 2012, a hospice paid $25 million to resolve allegations that it billed Medicare for continuous or crisis care services when the patients were not experiencing a crisis. And this hospice ended up with a 5-year corporate integrity agreement as a result of this settlement. For medical eligibility and appropriateness of the hospice benefit, notably in February 2013, a nonprofit hospice closed and declared bankruptcy following a government audit which was focused on patient eligibility. And this case was the result of a qui tam lawsuit that was filed by a former employee that led to a government audit and a payment suspension, which ultimately resulted in the hospice declaring bankruptcy and closing. And this is a very large nonprofit hospice, so despite what some reports and coverage would indicate, the government enforcers are targeting nonprofit as well as for-profit entities. Since the hospice declared bankruptcy, the government claimed $112 million in damages in the ongoing bankruptcy litigation. In March of 2013, an Arizona hospice paid $12 million to resolve allegations that it submitted claims for ineligible patients and that it adopted business practices and procedures to delay or discharge the ineligible patients, and this hospice also ended up with a corporate integrity agreement. Earlier this year, in May, the owner of a Philadelphia hospice was sentenced to 14 years in prison and ordered to pay over $30 million for a fraud scheme that included submitting claims for ineligible patients, routinely altering patient records, rewriting documentation to make patients appear sicker than they were, falsifying documentation for high-cost intensive hospice care. There were some additional allegations related to kickbacks provided to referral sources, and the owner was ultimately found guilty of conspiracy to commit healthcare fraud, 21 counts of healthcare fraud, 11 counts of money laundering, and 12 counts of mail fraud. So you sort of see all of those different criminal provisions that Jason mentioned earlier coming into play for one particular individual. Other individuals, including the medical director for this hospice, were also sentenced to serve prison time and faced exclusion from the healthcare programs. Just to touch on the marketing aspect, in March of 2014, the parent company for a hospice provider paid almost $4 million to resolve allegations that it had submitted claims for ineligible patients and induced employees and staff to admit those ineligible patients. And more recently, over the summer, the government decided to intervene in a case against Evercare Hospice in Colorado. And this suit is a combination of two whistleblower lawsuits that allege that the hospice submitted claims for patients who were ineligible and did not have a life expectancy of 6 months or less, but also that the management pressured employees and physicians to admit and retain patients who are not terminally ill, and then challenged or disregarded the physician's decisions that patients should be discharged. So really focusing on those census goals that we've talked about previously.
So, Sarah, in addition to the federal enforcers looking at healthcare fraud retrospectively, what are some of the other regulatory bodies doing proactively and prospectively to address some fraud issues that they suspect in the home health and hospice industry?
Sure, thanks, Dave. There have been a number of regulatory and statutory changes that were announced for the home health and hospice industries recently. Most notably, the Home Health PPS Final Rule was published at the beginning of November, and this rule changes some of these documentation requirements that we've been talking about. In particular, the rule changes the face-to-face encounter requirements by eliminating the requirement for a physician narrative for any start of care episodes that begin on or after January 1st of 2015, just about a month away. Instead of the physician narrative, the medical record of the certifying physician or the inpatient facility referring the patient must now contain sufficient documentation to support the certification for the beneficiary's eligibility. However, even though this change will go into effect in just under a month, until that time, CMS is continuing to enforce and audit compliance with the current physician narrative requirement. The final rule also made changes to the frequency of therapy reassessment visits, and this is a new timing requirement that home health agencies must begin to track. Also announced earlier in October, the proposed changes to the home health conditions of participation were published. And conditions of participation compliance is not classically thought of to be part of your typical enforcement efforts. However, the stakes are higher now because of the new intermediate sanction authority that CMS has been granted. In the 2013 Home Health Final Rule, CMS was authorized to impose intermediate sanctions on any home health agencies that are found to be out of compliance with the COPs as part of their survey and certification process. So in addition to terminating the home health agency's provider number and provider agreement, CMS may now impose alternative sanctions, including civil money penalties, the suspension of payment for all new admissions, temporary management of the home health agency, directed plans of correction, and directed in-service training. And some of the things that CMS is going to look at in determining whether they need to impose these intermediate sanctions are the extent to the deficiencies pose immediate threat or jeopardy to patient health and safety, the nature and incidence and manner or degree and duration of the noncompliance, repeated deficiencies, and any indicia of systemic quality issues. So in light of these potential intermediate sanctions, we really encourage home health agencies to take a good look at the proposed changes and think about how your organization can comply with these new requirements. The comment period for the home health conditions of participation was supposed to end actually this coming Monday, December 8th, but CMS has now extended the deadline for comments until January 7th. There have also been a number of recent regulatory and statutory responses that affect the hospice industry. Most notably, as of October 1st this year, debility and adult failure to thrive are no longer accepted principal diagnoses. And any claims with these diagnoses in the principal diagnosis will be returned to the provider for a definitive principal diagnosis coding. Debility and adult failure to thrive are still acceptable secondary diagnoses. However, we know that the government is tending to look at these two diagnoses in particular with scrutiny and has raised concerns about overutilization of these diagnoses. The IMPACT Act was passed at the beginning of October, and this includes some pretty significant changes for Medicare hospice providers. In particular, Medicare-certified hospice providers will be subject to mandated surveys at least every 3 years over the next 10 years. Additionally, the IMPACT Act requires that hospice programs with a certain percentage or number of patients receiving care for more than 180 days will be subject to medical reviews. CMS still needs to provide more information about how that percentage or number of patient threshold is going to be established. Additionally, we need more information about what the medical reviews will actually entail. But those are some real ways that statutory and regulatory changes are trying to get at the preventing fraud before it could occur. The IMPACT Act also included a new provision to align the financial cap calculation with the hospice reimbursement market basket update. Earlier this year, there was a bit of a snafu, for lack of a better word, related to Part D drug coverage and hospice care. And CMS wanted to make some changes in response to an OIG report from June 2012 that suggested that Medicare was paying twice for prescription drugs for hospice beneficiaries. And hospice is really responsible for covering all drugs for the palliation and management of terminal illness and related conditions. And any drugs that are unrelated to the terminal illness and related conditions continue to be subject to standard Part D formulary management practices and include things like patient copays. CMS tried to implement a pre-authorization for drugs and other changes, which led to a large number of issues, particularly for hospice patients who tried to fill their prescriptions at local pharmacies and were then denied necessary medications. This ultimately resulted in Congress and the other legislatures asking CMS to halt the implementation of these changes, and in response, CMS scaled back the changes so that as of October 1st, prior authorization is only required for 4 categories of drugs: analgesics, anti-nauseants, laxatives, and anti-anxiety drugs, because these are thought to be the types of drugs that all hospice beneficiaries generally need for symptom management during the end of their life, regardless of their terminal diagnosis. Now, part of what was highlighted during the Part D coverage issue is that there are still major aspects of the hospice benefit in flux. For example, CMS has not actually defined terminal illness or relatedness. CMS sought comments on proposed definitions for these 2 terms earlier this year, but then declined to implement the proposed definitions when they published the hospice final rule in August. So we would encourage people to monitor the CMS efforts to define these key terms because they really are going to continue to play an important part in the hospice benefit.
So as part of the Affordable Care Act in 2010, there were some other means of prevention of fraud in the healthcare and home care industries. Emily, what were some of those tools that were otherwise adopted by Congress?
So a number of these tools really focused on prevention of fraud and abuse from the very start through who is allowed to enroll in Medicare. From the starting gate, Medicare increased enrollment screening of providers entering into Medicare, and what they did was that they tiered the screening requirements by risk level, slotting providers into one of 3 groups: low risk, moderate risk, and high risk. As we mentioned earlier, newly enrolling home health agencies are in the high risk categories. What that means for those HHAs is that their owners are required to undergo fingerprint-based background checks. This requirement is being phased in. They started the phase-in in August, and so are beginning to kind of see this requirement taking shape over the coming months. Existing home health agencies and all hospice providers are in the moderate risk category. The additional scrutiny that they are subject to are unscheduled site visits. Another fraud and abuse prevention tool enacted under the ACA was the ability to impose moratoria on Medicare, Medicaid, and CHIP enrollment. The moratorium authority the regulations were enacted in 2011, but we didn't see CMS use the moratorium authority until 2013. And since that time, they have issued moratoria on new home health agencies in 6 cities, which are currently in effect. CMS is required to reevaluate the moratoria every 6 months, and they just recently did renew the moratorium in each of these 6 cities. CMS also has the authority to suspend all payments to a provider upon a credible allegation of fraud. This is a kind of tool that we've talked about a little bit earlier. What we have seen and how this is being rolled out in practice is that credible allegation of fraud is a really low standard. And this is a tool that CMS is using. As of September 2013, almost 300 providers are under active payment suspension, and that only 100 of these were improved in 2013 also signals that suspensions are being kept in place for extended periods of time. And this can eventually jeopardize or bankrupt a provider. So we see that payment suspension is a pretty powerful tool in CMS's arsenal.
So we have over 140 people participating today, and I'm sure that not only do they want to know how the enforcement trends are going, but they want to know how to mitigate some of that risk. So Jason, can you walk us through the 4th category of our agenda today?
Sure. Thanks, David. So I think when organizations approach risk mitigation, it really begins with the compliance program and the compliance officer. I think nearly every organization at this point, has a compliance program, but a fewer number have, what I would term an effective compliance program. At the risk of, I guess, sounding cliche, an effective compliance program, it's not a document or a person. It's not even the department. It's really the entirety of the organization acting ethically and responsibly, and that's of course especially true with respect to government program requirements. And one of the themes of ensuring that you have an effective compliance department is making sure that you're following all 7 elements of effective compliance. These are originally based on the federal sentencing guidelines. The OIG has adopted them and has released a number of very specific and targeted industry-focused compliance guidance documents, which are a great starting place, but it's really a starting place. Effective compliance is very narrowly tailored to the organization, and it has to constantly change and evolve. Someone at the organization, be it the compliance officer or a compliance liaison or risk management person, should be in a constant state of tracking potential risk areas. They change all the time. The government signals what it's looking at in its work plans. It issues fraud alerts, and someone should also be tracking, settlements and enforcement. I think a lot of what we've laid out in this presentation so far is a good starting place, but every year, particular risks to an organization will change, and a compliance program can't be something on a shelf that they have from a purely technical standpoint. We're not going to go through all 7 elements, but we do want to hit some of the most important pieces, particularly for hospice and home health organizations. It's absolutely critical now that we know the government is looking at medical necessity in particular, and also documentation to audit and monitor the high-risk areas. Most of the the auditing and monitoring activities of an organization are directed by the compliance work plan. The work plan is something that the compliance officer does annually, often presents it to the board, and it outlines what the areas of risk that the compliance officer believes are the most significant enterprise risks, and has a plan for how to monitor that. There's also a benefit to not only having the internal resources of the organization devoted to performing audits, but it's sometimes good to also get an objective third party to come in and audit records. This is especially true with documentation. I think organizations tend to have a certain way of documenting claims, and they train employees very consistently. And sometimes it's good to get an objective third party to really look at the way things are being documented to make sure it continues to pass muster. I'm going to say the most important thing institutions need to do as a compliance function is to not only audit, but also take action. There are a lot of institutions that audit, but they fail to return potential overpayments. And this can get you in hot water because now retaining a potential overpayment can trigger liability under the False Claims Act. So it's very important that those are done in a timely fashion. There also should be an in-depth review of government issuances. There's Pepper reports. The Pepper is the program for evaluating payment patterns, electronic reporting. These are issued by CMS, and they're a really, really great tool for particularly hospice organizations to assess where they stack up against their peers. There's a number of benchmarks that attach to use of certain codes. They also track long-stay patients and what proportion of their census is long-stay patients. And they allow the organization to see where it aligns in its geography with its competitors. And they have it split out by locality and also by state, and there's some national statistics. And it's presented in a graph form, and there's an 80% so-called at-risk benchmark that shows if the organization is an outlier, and if it is, that signals that it's probably ripe for an audit or some sort of government review. So those should always be examined very carefully. There's other home health metrics, of course, length of stay, diagnosis codes, utilization patterns, readmission patterns. For hospice, organizations look at live discharges. Of course, length of stay is always an issue. And use of certain primary diagnoses like COPD, Alzheimer's. There's a number of them that are quote, at-risk diagnoses that the government looks at. Those are typically good for focused audits. And finally, there's a hospice cap. There's a payment rule that tends to attach to hospices that have a high proportion or a higher proportion of long-stay patients. And if your hospice organization is making cap payments continuously, that may signal that, at least in the government's mind, you may have too many long-stay patients. Some of the things we tend to recommend is every couple of years do a compliance effectiveness review. This is conducted by a law firm or a third party, and it's really the report card for the compliance department. It looks at to see not only are the 7 elements being met, but how is the organization functioning vis-a-vis its compliance program? Are people actually using the hotline? Do they know about the hotline? Are there effective lines of communication? So it's not just a structural analysis, it's also a practical analysis. Targeted internal investigations. If during an audit or there's a particularly problematic piece that's been found, it's often advisable to enlist the aid of counsel to conduct a privileged internal investigation to get to the heart of something and respond accordingly. I think we talked a bit earlier about key TAMs being a significant risk factor, and neutralizing HR issues, I think, is very critical. Utilizing legal counsel to review financial relationships. This doesn't mean your lawyers have to look at every contract you have with referral source, but it's good to get a good template agreement. And if you're entering into a whole new type of financial relationship with a referral source, it's a good idea, at least from a global level, to have counsel review that, since this is an area that has been a particular focus for the government. Finally, and this is low-hanging fruit, you have to make sure that you're not doing business with anyone who's excluded. There's 2 databases that need to be checked, and this is something that can very, very easily be done internally or inexpensively using an external source.
So focused training and education around risk areas is another way to help prevent issues or to identify them early on. And as Jason suggested, an easy tip is to designate a specific individual to be responsible for tracking and understanding regulatory changes if there's not someone in your organization that's already doing that. It's not unusual to find that everyone assumes that someone else in the organization is keeping track of changing rules and emerging risk areas and the issuance of new guidance, and that we see things fall between the cracks. And so that's an important and an easy way to stay on top of risk areas. We've seen that many home health and hospice enforcement efforts and audits include documentation issues. We've talked about a number of them so far today. So therefore, you want to make sure your staff are well-versed in the documentation requirements, not only so that they complete documentation correctly, but they help monitor the documentation compliance of others. Both in home health and in hospice, some of the documentation is completed by physicians external to your organization. And still, the onus is on you to ensure that it's accurate and complete, because it's the home health and the hospice reimbursement that's at risk. Documentation, training, and compliance for physicians is important as well. A perfect example with regard to documentation training is conducting training now on the new home health face-to-face requirements. There's not, I think providers may feel there's not a lot of clarity out there on the new rules, but there is some guidance from CMS in the final rule. Make sure your staff understand what information will be required to support the claim, what CMS's position is currently. Develop internal processes and educate your staff and your physicians on what you're going to be doing on a going forward basis starting in the new year. For example, HHAs are allowed to provide the physicians with copies of their own records to help ensure that there's adequate documentation. What procedures will home health organizations have to make sure that those records get shared? Additional important training is training for marketing staff on their interactions with referral sources and beneficiaries. We've talked about this a bit so far today. Develop a do's and don'ts resource, and then update it whenever there is additional guidance from OIG and other sources. And then finally, we just want to point out that in connection with the HEAT initiative, OIG has developed a number of resources that are available to providers to assist in developing and implementing a compliance program. They also have developed a number of training aids. Podcasts, videos are available on the website that you can use. Take advantage of these resources because they were developed by OIG. They are valuable resources. They're easy resources to use, and they were developed by the very agency that assesses whether compliance programs are adequate.
Another thing that organizations can do to help minimize their risk is to really pay attention to the questions, complaints, and issues that are raised through your compliance program. In addition to tracking what kinds of questions and complaints are raised, it's also important to track how those issues are raised, whether they come through email or a compliance hotline, because this can help give you a sense of whether your compliance program is effective. It's also important to track any investigation or follow-up that is done, and then the ultimate resolution, including corrective or preventative action. Organizations can also take time now to figure out the capabilities of their systems for helping with compliance. In particular, we've talked a lot about how important documentation requirements are in the home health and hospice industries. Many electronic medical records have features that can be used to help identify patients that have upcoming recertification requirements, which can help the organization make sure that all of those pieces are completed in the required time frame. It may also be a good idea to make sure that you have systems in place to help with scheduling clinical meetings so that these key timing requirements are met. Many of the enforcement actions that we've talked about were initiated by former employees. So it's a good idea for your compliance program and your human resources department to have a connection and a way to identify any potentially disgruntled employees or contractors. You want to conduct exit interviews so that ask any leaving employees about their concerns, so that hopefully the next time you hear from that employee, it is not because you've received a key TAM complaint alleging that you didn't pay attention to the concerns they raised. It's also important to remember that contractors and vendors can also be whistleblowers, so you want to make sure that those contractors and vendors know how to raise concerns if they have any with your organization. Finally, it's important to pay attention to the payer and contractor audits you receive to look for patterns that may indicate you have a systemic issue. Certainly, some document requests and audits are normal. Unfortunately, that's just become a regular part of doing business. But if you notice an uptick in the number of requests or you receive multiple audits focusing on the same or similar issues, or you receive multiple ZPIC or RAC audits, that may indicate that you have a larger systemic issue looming. And it can be helpful to try and figure out what those issues are before a larger government enforcement action shows up at your door.
Government overtures. So I guess this is a part of the presentation where if compliance has not neutralized all threats, then the government actually launches an investigation of what to do. I guess from the outset, it's really, really important to understand that there's a number of different types of overtures the government can make. They don't always look alike, and they're sometimes difficult to discern if you don't work in this area routinely. Some things are benign. There can be requests from a MAC, routine audit request that's done in the normal course of business. And there are things that are not benign. Commonly confused are ZPIC audits. A ZPIC is not a benign request. If you receive a request from a ZPIC, it looks like a government contractor request, which you may believe you're familiar with, but a ZPIC is a contractor that is really targeting fraud and makes recommendations to the U.S. Attorney's Office. So contrast that with a RAC, which is trying to find overpayments and does automated recoveries, or a MAC, which may just be looking at routine a routine claim that's not supported. So this isn't about reading tea leaves. It's critically important that the individual who is intaking and reading the government overture knows exactly what these mean, because these particular overtures greatly signal government posture, and they certainly inform your immediate strategy. What to expect? So the government may send one of these in the mail. They may show up at your door and serve a subpoena. They may also show up unannounced and request interviews or demand immediate access to documentation. It's their right to do so. They may also execute a search warrant. Now, obviously, if a search warrant is executed, you know you're under investigation. But some of these other ones are it's less clear to the uninformed. So it's very important to involve counsel early. The process of a government investigation, to those who are familiar, can be painful. They tend to request a lot of business records. Business records may include email, internal files, correspondences. They may also request a substantial amount of medical records and billing, coding records, and other electronic platform records. So they tend to be very involved. And organizations should be prepared that their own interpretation of Medicare guidance, Medicaid guidance may differ greatly from the interpretation by the U.S. Attorney's Office, and this could be particularly frustrating. I think also giving some of the conflicting regulatory authorities out there, but it's something that every organization has to struggle with. So, responding to a government overture, I think we could devote an entire webinar to what to do and how to handle an investigation. But I think for purposes of brevity, an organization should know what to do. Some good questions to think about is, who's in charge of responding to a written request, and who's responsible for determining what threat level that request actually poses. Who tracks what's been given to the government, and how's that documented? What does the front desk do if an agent arrives? What do employees do when the agent is on premise? And what happens if an employee is approached by an agent outside of work, which happens all the time? They show up at employees' doors at 6 a.m. If you don't know the answers to these questions, now is a really good time to figure that out. Given the enforcement climate for these two industries, it's critically important to have a sort of a ready, government-ready training. Whoever opens the mail, whoever answers the phone, greets people at reception, is likely to be the first person to know about a government overture. Train them. Train everyone else in the organization who understands who to contact and what the chain of command is if a government overture has been made. Try not to leave it to chance that an employee is going to do the right thing. When the government shows up, people do what they typically do, and they try to be helpful. And in some cases, they disseminate inaccurate information, and it can be particularly damaging to an institution. It's very, very important in handling these investigations to build trust and a good rapport with the government. The whole linchpin of the relationship really is built on that foundation of trust. And it's incredibly important to be organized and have an accurate response. So, organizations shouldn't be caught flat-footed if the government shows up or if they receive a demand or a subpoena. Everyone in the organization should be trained on what to do. Some of the immediate steps, I think, are more obvious ones. Calling counsel was always a good idea. If you're dealing with an agent who is on the premise, whether it's a search warrant or otherwise, you can't tell individuals not to talk to federal agents outside of business hours, and you shouldn't otherwise interfere with the investigation. But if possible, businesses have elected to close down early and send non-essential employees home. You can also offer counsel to your employees who it's their right to tell agents they would like counsel present if there's a request for an interview. If a search warrant is being executed or the agents are walking around collecting documents, it's a good idea to have someone shadow them, again, not interfering, but taking very careful notes of the agent's activities. And certainly if the property is seized, to keep an inventory and get a receipt from the agent on what's been taken. The other, I think, very critical thing to do in those first couple days is to make sure if there is a document request or the agents have otherwise signaled that they're interested in something in particular, that information is being preserved. We're in the electronic age now, and backup tapes are routinely overwritten, and people delete email, and it's very easy to destroy information. So it's very important to circulate a document destruction memo that instructs individuals not to destroy things, delete email, at least until counsel is contacted and the scope of the government request is better understood. And it's also very important to enlist the assistance of IT, because they really hold all the information to make sure that they're suspending their auto delete functions and purging functions. And then counsel can always make arrangements to have things forensically preserved if needed. But a lot of what you do in those first 24 hours is absolutely critical to the ongoing success of an investigation with the government.
So we have, as expected, a number of moments left, about 10, to answer some questions that people have raised. The first question that has been raised is the availability of the PowerPoint presentation, and as a reminder from the beginning, Whitney, can you explain to everyone where and when it will be available?
Yes, the PowerPoint presentation and a recording of today's webinar will be available in 2 to 3 business days. It will be emailed to all registrants and attendees.
Terrific. Some of the other questions that have shown up through the Q&A function. First question, there was mention earlier of the moratorium on new enrollment. Does that apply only to home health, or in those cities that were mentioned, is hospice also subject to the moratorium?
So the current moratoriums that are in effect are specific to home health providers in those cities. They do not presently include hospice organizations.
So, and this is kind of a follow-up question that I think many may have, is in addition to this moratorium, there's a 36-month rule for changes of ownership. And what's the interplay between that and home health and hospice?
So the 36-month rule applies only to home health providers. Once again, it is not applicable to hospice providers. It's a rule implemented by CMS. It's a regulation, and it regulates and governs the frequency with which home health agencies can experience a change of ownership right at the provider level. There can be a majority change of ownership of more than 50%. If those happen more often than within 36 months, Medicare is going to require the agency to re-enroll as though it's a new provider. And so the interplay with moratorium is that if you're a home health provider contemplating a change of ownership in a city with a moratorium, there needs to be kind of a lot of paying of attention to structuring the transaction because you may not actually be able to re-enroll as a provider.
So another question that has been asked is whether or not the size of an organization matters as to whether or not the government is interested in pursuing any type of investigation. Jason, what's your perspective on that?
I think years ago I may have answered this question differently. I would say currently, no. I don't think you can be too small at this point. We're seeing, in particular with these two industries, that there is a lot of enforcement for small entities, and a lot of it's been criminal. There's been a number of targeted sweeps of very small institutions. And I would also note that, with the payment suspension rules being what they are, which are very draconian and quite onerous, and they could put a business, put a company out of business very quickly, in particular have attached to a lot of small institutions. So, no one is, I think, at this point too small to fly under the radar. And I think it's a mistake now to think of this particular enforcement climate as a government of limited resources. There have been so many, state and federal initiatives and so much funding thrown at curbing, fraud and abuse that no one is really safe at this point. And quite frankly, data mining and a company's own employees through the key TAM provisions, whistleblowers, both of those things they're great equalizers, and every company is subject to both.
Terrific. A question that's not directed at any one individual, but for the panel as a whole, talks about or asks about franchises and whether or not a home health provider can enter into a franchise agreement in which the franchisor receives a percentage of the gross revenues. Any perspectives on that?
So I would say that there's nothing per se wrong with franchise arrangements. However, when you move from a purely franchise for the use of name and advertising efficiencies to getting more involved into the day-to-day management, billing, coding practices, things like that, the use of a percentage of gross revenue can become more questionable. Those are things to keep.
This one's directed to you, Sarah. Was it a statement of yours that CMS never finalized the definitions of terminal illness and relatedness for hospice?
That is true. Although they proposed definitions in the proposed rule for the hospice wage index earlier this year, in August, the final rule, they specifically declined to actually define these two terms. And one of the reasons we want to stress keeping on top of these definitions is because these two terms really get to the heart of what the hospice benefit covers for a particular patient. The hospice is, as we said earlier, responsible for providing any and all services that are indicated in a plan of care that are reasonable and necessary for the palliation and management of the terminal illness and its related conditions. So in order for Medicare to cover something that's outside of the hospice benefit for a patient who has elected hospice, that thing, the condition, the drug, whatever, must be completely unrelated to the terminal illness and related conditions. So these terms are important not only from a regulatory and a compliance perspective, but also from a business perspective. Because the hospice provider is required to provide those reasonable and necessary services and care to patients, you want to make sure that the comprehensive benefit, from a business perspective, you're aware of what care the hospice is or is not responsible for covering. And this really becomes an issue in things like Part D drug coverage, as well as some hospitalizations for beneficiaries who have elected the hospice benefit.
So a question from one of the participants is whether or not the development and use of the hospice cap has been effective or ineffective at stopping the admission of patients who turn out to have a long length of stay. Any perspectives on that?
I think you'd have to answer that question depending on whose perspective. I think the government would say no. I think that the government would say that there's a specific need to continue to enforce in this area, notwithstanding the cap. The thing about the cap is that the denominator and numerator they're based on the total number of patients the hospice has. So if a hospice has a lot of short-stay patients and few long-stay patients, the cap might not apply, but those few long-stay patients may not be medically necessary. So I think it certainly does curb it. I think hospices are aware of that, and they've had to make cap refunds. But I think from the government's perspective, it's not enough, and it's one of the reasons why they've really focused on long-stay patients.
So as we're coming to the end of our time, this last slide, which again will be included in the materials that are emailed to everybody, are links to a couple of resources on EVG's website. The first two are some client alerts, both in terms of proposed regulations when they came out over the summer, and then most recently some of the new regulatory landscape issues that have arisen, with the last one being specific to the hospice industry and a document that the advisory board company has put out on hospices and audits under the Impact Act. So that brings us to the end of our time. Whitney, can you wrap us up?
Sure. Thank you for joining us. This concludes today's webinar. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials.